All right, next is cardiomyopathy. Cardiomyopathy is when the heart muscle itself is not working effectively. So there are different causes. It's pretty rare in children. When it occurs in children, it's likely to be a familial or genetic disorder. It can be idiopathic, just happens. It can be a genetic disorder. It can be after an infection. It can be due to a metabolic abnormality. It can be due to a vascular disease, a collagen disease, or it can be due to drug and chemical toxicities. One example of that is some types of chemo cause cardiomyopathy. So what happens is the heart muscle itself becomes weak and unable to effectively contract and move blood around the body. There are different types. There's dilated, hypertrophic, and restrictive. Okay, so dilated cardiomyopathy, the ventricles are dilated, they stretch bigger, but they don't contract well. Okay, so they're dilated with poor contractility. This is the most common type in children. The cause is unknown. It causes heart failure and dysrhythmias that are hard to control, because if the blood can't go forward, it goes backward, okay, or it builds up and we start getting fluid buildup. So dilated cardiomyopathy causes heart failure. Hypertrophic cardiomyopathy is when the heart muscle mass increases without increasing the cavity size. So for some of those disorders that cause the heart to have to work harder and build up the muscle hypertrophies, they build up more muscle, that takes up space that the blood would be in because it doesn't increase the size. It's more common in the left ventricle. It can happen in the right ventricle with things like pulmonary artery hypertension, like we talked about a minute ago. It's most common in the left ventricle. This can be familial or genetic. The symptoms usually begin in school age or adolescent child. It leads to chest pain, dysrhythmias, and syncope. A child who has unexplained syncope with a known hypertrophic cardiomyopathy has a 60% risk of sudden death within 5 years. If they have symptoms in infancy, it usually begins with heart failure and they have a poor prognosis. But when they're older, the symptoms are going to be of inadequate cardiac output. Restrictive cardiomyopathy is restriction to ventricular filling caused by either endocardial or myocardial disease, but without any dilation or hypertrophy. So there's something that's keeping the heart from filling, and it presents with heart failure. Medical management, they want to correct the underlying cause if possible. The causes that are correctable are rare in children. So usually children with cardiomyopathy, it's more about management. For dilated cardiomyopathy, they want to manage heart failure and dysrhythmias. They're going to get digoxin to improve the strength of those contractions. Remember how dangerous digoxin dosing is for kids. So we've got to do a lot of teaching with those parents. They get diuretics to try to get the fluid off, and we want to reduce the afterload, which is what makes it harder to push the blood forward. So we want to make sure that their blood pressure stays down. We don't want them with hypertension. Hypertrophic, this is when the muscle's too thick. They get beta blockers and calcium channel blockers that helps improve the rhythm, and it helps to improve cardiac output without making the heart pump harder, because if we make it pump harder, that makes the hypertrophy worse. Dysrhythmias are treated. They may have dysrhythmias are treated as they happen, but if they're at risk for sudden death, they may have an automatic cardioverter defibrillator implanted. They need anticoagulants because they're going to be at risk. Blood that can't move forward is more likely to start clotting, so they're at risk for clots and anticoagulants. Kids who are severely ill with cardiomyopathy are going to get IV inotropes like digoxin and vasodilators to try to decrease the afterload. Heart transplant may be an option for some people with cardiomyopathy. Nursing care, this is a life-threatening disorder, and we need to be able to support that family and child. The child needs to be included in discussions, especially as they age. These tend to be progressive, so they get progressively sicker, and the child needs to be included in discussions about planning their care. Kids who've had a heart transplant, first is the evaluation piece. Indications for heart transplant are if their heart failure is worsening and their life expectancy is limited, even though they're getting the maximum intervention. So they've done everything else to try to maintain, and they're still getting sicker. They also evaluate the potential for other options. If they have conditions that may decrease the chance of success, they may not be accepted for heart transplant. They do a psychosocial evaluation to try to help determine if the family can comply with post-procedure care. This we have to be cautious about, because in that psychosocial evaluation, bias can affect that evaluation. And then they need to make sure that the family has a good understanding of risk and benefits. Kids and adults who've been approved for a heart transplant are then put on a waiting list, and the waiting list is ranked by severity of need, not by how long they've been waiting. So the sicker they are, the higher they get on the list, but also the sicker they are, the more potential that they will either die on the transplant list or that they will get too sick for the transplant. So waiting list mortality is high because there aren't a lot of heart transplants available. Ventricular access to assist devices are decreasing mortality. You've all seen the LVAD scene with Denny in Grey's Anatomy. An LVAD is a left ventricular assist device, and that device actually just helps with pumping the blood. Post-heart transplant, heart function is either normal to greatly improved, so they tend to get a lot better. They can return to normal activity after that recovery. They have to take immunosuppressants for life because the risk of rejection of a heart transplant is very high, and there are some serious systemic side effects for those kids. The long-term risks are chronic rejection causes coronary artery disease, renal disease, and hypertension, secondary to cyclosporin, which is one of the potential immunosuppressants. And because they're immunosuppressed, they're at risk for infection and sepsis. Okay, next section, we're going to talk about valve disease.